Hello everyone. So for my presentation today, I'm going to be talking about flesh-eating bacteria, or as is clinically known as necrotizing fasciitis. My name is Aisha Khan, and this is for a community medicine seminar. So really quickly, a brief history. So in the 1871 is when it was first described during the Civil War by an army surgeon. And 1918 when it was first described as, or identified as, a bacterial infection. And it wasn't until 1952 that it was named necrotizing fasciitis. Necrosis meaning the death of a portion of a tissue, and fascia meaning fibrous tissues that enclose and connect muscles. So some background. Although it sounds like it's from science fiction, a flesh-eating bacteria, it is in fact true that it spreads through human tissue at a rate of 3 centimeters per hour. About 25% of its victims die, and in severe cases, death may be as quick as 18 hours. So we've all heard of strep. It's short for streptococcus, but most commonly manifesting itself as strep throat. But depending on the strain and the immune system, it can affect the human body in many ways, and some can be fatal. Depending on the strain, it can affect cardiac valves, can affect muscles, can infect bone, but problems arise when there are strains that can infect our bloodstream. This can cause generalized disturbance to cardiac function, lung function, and is termed septic shock. And this can lead to necrotizing fasciitis, which is a horrific destruction of soft tissue. So how did this bacteria evolve? In a recent study done in 2014, we found out that in the 80s this bacteria wasn't even very virulent, that it suddenly turned into a worldwide epidemic. And this was a cause of two main events. Just like humans, bacteria can be infected by viruses. And a bacteria cell of a group A strep was infected by a virus through a horizontal gene transfer. And this caused for regular mutations of the genes of that bacteria to be upgraded into a more toxic form. And then it was attacked again by a virus that had already attacked a strain of group A strep. This made the bacteria even more severe in terms of growth and infection, and is now turned into the type 2 form of group A strep we know today. So there are three types of neck fash, and the first type is the most common. Although these are labeled in terms of severity, all three require prompt emergency treatment. So the first type includes bacteria such as Streptococcus, Klebsiella, E. coli, Staphylococcus aureus, and Vibrio. And type 2 is caused by the group A streptococci we were talking about. There is no vaccine against this, and it is known to cause hemolytic streptococcal gangrene. The third type is Clostridium species. It is the most lethal and fast-acting. It is also known as Clostridial myonecrosis or Clostridial gas gangrene. And there's two types of those. There's traumatic and spontaneous. Traumatic is usually seen after an open wound or surgery, while spontaneous is seen in immunocompromised patients, such as one suffering from HIV or leukemia. Transmission. How is this transmitted? Is really through anything. If you have an open cut, sore, scratch, and you're exposed to this bacteria, you have a very high risk of infection. And also, it is seen in immunocompromised patients, like ones dealing with chronic diseases such as diabetes or chronic kidney disease, HIV, IV drug users, or anyone that has experienced blunt or penetrating trauma. Signs and symptoms. If you see a small red painful bump near your abrasion and it feels very warm, or there's a painful bruise-like area that starts developing very rapidly, sometimes less than an hour, and the skin may even break open or ooze fluid. Other feelings are having fever, sweats, chills, nausea, dizziness, and shock. So the way that it's usually diagnosed is through ultrasound, X-ray, CT scans, blood tests, cultures, and a tissue biopsy. And another risk score that's used is the LRENIC, which is a laboratory risk indicating score. And in a recent study in 2012, it was found that although this is great from discerning neck fash from an abscess or a cellulitis, it's not exactly useful for early recognition. The highly risk groups, as I stated before, are immunocompromised patients, and unlike other diseases, it's not one to target a gender or an age group more so than another. Anyone really is at risk. Prevention strategies include always thoroughly clean your wounds, cuts and abrasions, keep an eye on your wounds, check to see if you're having any fever, pain, redness, and then proceed to your emergency department immediately if you see any of those signs. Case management includes admission to the hospital, IV antibiotics, surgery to drain the sore and remove the dead tissue, and special medicines include immunoglobulins. Other case management strategies include skin grafts, amputation, and 100% oxygen in a hyperbaric oxygen therapy as shown to regrow healthy tissue as well. These are my references. Thank you.